Welcome to our webinar titled Bone Marrow Failure Syndromes, Helping Kids Understand. Thank you for joining us. My name is Cooke Harris, and I'm the Manager of Learning Events for the Aplastic Anemia and MDS International Foundation, and I will be moderating the presentation today. As we get started, I would like to acknowledge Alexion Pharmaceuticals, Amgen, and the Celgene Corporation for providing educational grants to help support this and other webinar education programs. I would also like to share with you some additional educational opportunities that you might be interested in. This year, the Aplastic Anemia and MDS International Foundation is hosting 7 regional conferences on living with aplastic anemia, MDS, or PNH. These free regional conferences will occur around the country and are designed to make information on bone marrow failure diseases more accessible to patients and families. Please visit our website, www.aa&MDS.org, for more information on the conferences and all of our learning events. I would now like to introduce our speaker for today, Dr. Kenneth Cooke. Dr. Cooke is currently the director of the Pediatric Blood and Bone Marrow Transplant Program at the Sidney Kimmel Comprehensive Cancer Center at the Johns Hopkins University. He previously served as the director of the Pediatric Bone Marrow Transplant Program at Rainbow Babies and Children's Hospital, and he was also an associate professor in pediatrics at Case Western Reserve University School of Medicine. He trained at the Children's Hospital of Philadelphia and Boston Children's Hospital. Dr. Cooke is the principal investigator on 2 national multi-center trials for the treatment of idiopathic pneumonia syndrome in both pediatric and adult transplant recipients. He is internationally recognized for his laboratory and clinical research. He recently served on the American Society of Hematology Scientific Subcommittee on Stem Cell Biology and the Board of Directors of the American Society of Blood and Marrow Transplantation as the Director of Laboratory Science. At this time, I would like to welcome Dr. Cooke and turn the program over to him. Dr. Cooke.
Thank you, Cottrell, and thank you for that warm and kind welcome. It's a pleasure to be here this morning to talk to all of you about bone marrow failure syndromes, particularly as they relate to children. As Cottrell mentioned, my area of expertise is in blood and bone marrow transplantation, and a significant focus of this presentation will be on understanding stem cells and the role that blood stem cell transplantation plays in the treatment for bone marrow failure syndromes. So the goals of this presentation are listed here. Firstly, and as mentioned, I'd like to introduce the concept of hematopoietic or blood stem cells. We'll then talk a little bit about the location of these blood stem cells, why they are so important, and how they are collected. Thirdly, we'll have an overview of hematopoietic or blood stem cell transplantation. We'll highlight some of the recent advances made in blood stem cell transplantation with respect to outcomes for patients with severe aplastic anemia and other forms of marrow failure. And ultimately, we will review existing barriers to successful outcomes of blood stem cell transplant and address some of the areas of new and exciting cutting-edge research in the area. So I wanted to start out with a brief description of 2 key features of stem cells. Stem cells are very, very important cells in our body, and the 2 key features are listed here. Firstly, for all of you kids out there, think about these cells and their need to be grandma cells. And what I mean by that is that a stem cell needs to be able to make all of the other cells in a given biologic lineage in your body. So this is depicted here by Her Majesty Queen Victoria and all of her royal descendants, in this case in her family tree. A blood stem cell then has to be responsible for making all of the other cells in the blood and immune system. In addition, however, and perhaps as importantly, these blood stem cells have to be able to self-replicate or self-renew. So imagine, if you will, your grandma being able to make herself over and over and over again. This is very important because stem cells need to be around for the entire life of an organism. And in the case of blood stem cells, they need to be able to make all of the cells of the blood and immune system for your entire life. It's also important to realize that not all stem cells are created equal. some stem cells, for example, can give rise to a whole new person. And these cells are called embryonic stem cells. And we're not going to talk too much about embryonic stem cells today, but rather we're going to talk about blood and other non-blood stem cells that can be comfortably collected from healthy newborn babies, from healthy children, and healthy adults. In the case of newborn babies, stem cells are collected from the umbilical cord, and it turns out that the placenta, an important organ that helps feed the baby prior to his or her birth, is a very, very rich source of both blood and non-blood stem cells, and we can collect these stem cells through the umbilical cord. In healthy children and adults, the preferred spot to obtain stem cells is the bone marrow, and we're going to talk more about that in the slides that follow. In each case, both blood or hematopoietic and mesenchymal or non-blood stem cells can be collected, frozen, and distributed for a number of different purposes. So let's talk about those blood stem cells and why they're so important. As I mentioned, in healthy children and adults, the preferred spot to collect stem cells is the bone marrow. And the next time you sit down for dinner and have chicken or turkey or something like that, where you'll ultimately have a bone in hand, have your mom or dad put that bone aside and let it dry. And later crack that bone open. That purple, magenta, brownish color that's inside the bone is the bone marrow. And this is a very important space. In simple terms, the bone marrow is the factory from which all of the cells of the blood and the immune system are made. And in fact, you may have already guessed, the important factory workers are the blood stem cells. So in this case, a blood stem cell can give rise to all of the other cells in the blood and the immune system. It's truly a spectacular array, as you can see in this slide. And the important cells to consider are shown here. Firstly, white blood cells, including monocytes and neutrophils and eosinophils and basophils, all of which have spectacular colors under the microscope, are very important for fighting infection and keeping you healthy. Secondly, red blood cells are very important for carrying oxygen to your body and giving you the pink color that everyone likes to see when they meet their grandma and grandpa after not being seen for a while. And then finally, blood stem cells also give rise to platelets, and platelets are a very important factor to help clot your blood. So where are these blood or hematopoietic stem cells? Well, as I mentioned, they are in all of the bones of your body. And any of you patients who've had your bone marrow sampled before know very well that most of the doctors and nurses are going to look at the bones that are in your hips or right along your back where your belt buckle would be. And as I mentioned before, the bone marrow is a factory where all of the special cells of your blood and your immune system are formed. And as you can see here again, this includes white blood cells, red blood cells, and platelets. For any of you patients who are listening or watching, you know that many times your doctor or nurse will lay you down, usually after getting some medicines to make you go to sleep, and a needle is placed through the skin and into the bone of your hip. And then we can sample some of the cells, those factory workers that are present in the bone marrow factory. In addition to the bone marrow space, other sources of blood stem cells are the placenta or the umbilical cord. And also sometimes we can actually get these cells right from your blood, and we'll talk more about that later. Once we take a sample of your bone marrow, this is how it looks under the microscope. The bone marrow factory is usually very full. And as you can see here on the left-hand side, the bone marrow is actually made up of several elements. The pink is actual bone, the white is fat, and the purple colors are those blood stem cells and all of the other cells that they give rise to. And under the microscope, again, this is an incredible assortment of colors representing all of the blood cells of the blood and immune system. Keep a good eye on this because this is a healthy bone marrow, and in some slides that follow, you will see examples of bone marrow that is not as healthy. Sometimes it gets confusing when we talk about blood stem cell transplantation. Your mothers and fathers may hear a number of different phrases used to describe this procedure. One of them is called bone marrow transplant, which would make sense because we are taking cells right from the bone marrow. This can also be called stem cell transplantation, hematopoietic stem cell transplantation. Remember, hematopoietic is a special name for blood. We can also call this peripheral blood cell transplantation. If we get the stem cells from the cord blood, then the term used is cord blood transplantation, and we also use the term hematopoietic cell transplant. So this can get quite confusing. And the term that we many times will use is hematopoietic or blood stem cell transplantation. And that's the term that we'll use for the rest of the talk. So as we think about blood stem cell transplantation, one of the very important things to remember is there are two main types. The first type is called autologous. In this case, the stem cells are collected from the patient. The stem cells are collected in advance. They are then frozen away in a special freezer, and then later they can be thawed and reinfused, sometimes after patients receive high doses of chemotherapy. The type of blood stem cell transplant that we usually use in patients with bone marrow failure syndromes is called allogeneic blood stem cell transplant. This is the transplantation of blood stem cells from someone other than self. In this particular case, the donor has to be matched with the patient. Usually, this is a sibling or another family member. However, if a sibling or family member does not exist and does not match, then sometimes we can use unrelated volunteer donors. And we can find these donors in the adult Be the Match registry or in one of the many cord blood registries that are now available. It's important to know that blood stem cell transplantation is currently a curative option for many, many blood disorders and many types of other cancers. Well, how are these blood stem cells collected? Well, this is a picture in the operating room, and one of the first ways to collect blood stem cells has been through something called a bone marrow harvest. In this case, those stem cells are obtained again from the pelvis or the backs of the donor. The donor is actually in the operating room, and the donor requires special medicines to put the donor to sleep. The donor is now depicted here by the green arrow, and the head is up toward the front, and the patient's bum is right here. So you can see that the physician and nurse are trying to get those stem cells from the back of the donor right along the belt line. The juiciness of the stem cell collection is operator dependent, meaning that the doctor and nurses collecting the stem cells have to take their time and do a real good job to get the very best stem cells they can. Another way to collect blood stem cells is through a machine, in this case called the Cooke spectra. This is called peripheral blood stem cell collection. The stem cells in the bone marrow are actually mobilized or released from the bone marrow and into the bloodstream. And this is done using a variety of growth factors, one of which is called Neupogen, or GCSF. The cells are then collected in the blood. The patient or donor can be connected to the machine by catheters that are in place either in the chest or the arms of the donor. The machine then removes the blood of the donor and separates out the important stem cells that have been released from the bone marrow and into the blood. This procedure has a fancy name called leukapheresis. Leuko is another name for white blood cells. In this case, the donor does not require anesthesia, so this is a bit less risky in terms of collecting stem cells from the donor. The third way to collect blood stem cells is from the cord blood. Remember what I had mentioned before, that the placenta, which is a very important organ that helps nourish a baby before birth, is enriched with many of these specialized early or primitive stem cells. Importantly, as we all remember, babies have an immature immune system. And because of that immaturity, these stem cells have been found to be a bit safer following transplantation. These cells can be collected without danger to the mom and the newborn infant, and then they are frozen and stored away in special freezers. In this case, they are ready to go, which means there is less time needed to arrange for collection and disbursement of those cells should a patient need a cord blood stem cell transplant. Well, what is the preferred source of stem cells? How do we know which stem cells we should use, particularly when we're talking about our pediatric patients? This is a graph that shows stem cell transplants completed by the National Marrow Donor Program by Cell Source. On the very bottom is the year, starting back several decades ago. The blue stem cells are from bone marrow, the green stem cells are peripheral blood, and the orange stem cells, shown here, are from cord blood. And it's important to know that just at the start of the 21st century, there was a significant increase in the use of cord blood stem cells, and that has continued over the last 10 to 15 years, particularly in the pediatric patient population. So what are the potential reasons to do a blood stem cell transplant? What are the applications? Well, remember what I showed you earlier, a picture of that healthy bone marrow. Remember how it was full, and it had the constellation of beautiful purple-colored cells in addition to bone and fat elements. That is a healthy bone marrow shown here on the left. Well, in the case of severe aplastic anemia, which is shown here on the right, those factory workers have gone on strike. They are no longer showing up to the factory and producing the blood cells that are required to sustain life, to carry oxygen to your body, to fight infection, and to help clot blood. This is not a good situation. And when the bone marrow is empty or aplastic, particularly when severely so, this is an opportunity for a blood stem cell transplant to be used as a curative treatment option. There are other forms of treatment for patients who have aplastic anemia, particularly if they don't have a suitable family match. And those medications help suppress the immune system. It may include ATG, cyclosporin, and sometimes Cytoxan. But if someone has a good matched family member, blood stem cell transplant is the way to go. Another problem that can be remedied by blood stem cell transplantation is something called myelodysplastic syndrome, or MDS. In this case, the workers come to work, but they are making defective products. This is a problem with the factory workers, and in fact, the problem leads to a decreased or problematic production of defective cell components. This results in lowering of the blood counts, and that causes anemia or low blood, increased risk of bleeding, and increased risk of infection. Many times patients with MDS will have a predisposition to developing cancer or leukemia, and in these cases, blood stem cell transplantation is the only known cure. Now, what happens when people develop full-blown leukemia? Well, if you can see here on the left-hand side, this bone marrow is completely packed. The factory workers have gone a bit crazy here, and in fact, the bone marrow factory has been replaced by renegade workers. They have crowded out all of the good workers, and if we focus down on an area of the bone marrow, we see that these leukemia cells have now taken over. Unfortunately, all of the good factory workers have left. They have run scared. These leukemia cells can be quite angry and can cause a lot of problems to our patients. Our patients, again, become anemic, they have problems with infection, and they have problems clotting their blood. In this particular case, these bad leukemia cells need to be killed off, and that is done by the delivery of chemotherapy. Blood stem cell transplant, as it turns out, is a frequently used treatment to cure adults and some pediatric patients who have leukemia. So how is this blood stem cell transplant procedure actually completed? This is an example of a patient who may have had leukemia and came into the hospital for a transplant. Can you see those hidden leukemia cells? amidst all of the patient's blood stem cells. The patient blood stem cells are in pink, and those hidden leukemia cells can be seen behind them. In this case, the leukemia cells can be few in number, but they still may be present. The patient is taken into the hospital, and for the first 7 to 10 days, the blood stem cell transplant team may deliver chemotherapy and sometimes radiation. What this ends up doing, it gets rid of those hidden leukemia cells, but it also gets rid of the patient's blood stem cells as well. After the chemotherapy is given, donor stem cells are collected, and they are then infused through special catheters that are placed in our patients. Now these donor or D stem cells find their way into the blood and into the bone marrow of the patient. And after some time, they set up shop there and then begin to give rise to all of the cells of the blood and the immune system, the white cells, the red cells, and the platelets. One of my dear colleagues, Dr. Margolis, calls this the blood cell garden, because these donor stem cells are like seeds, and over the course of time, they have to give rise to a variety of flowers that help deliver oxygen, clot blood, and protect us from infection. What does this look like over a timeline? Well, this graph shows the day of transplant on the top, day 0 being the day the donor stem cells are infused, day 21, a day generally when the donor stem cells will grow back, and day 100, a time where patients can be out of the hospital and back trying to live more normal lives. Over the course of time, in the weeks before the transplant procedure, we have to do special tests on our patients to make sure that they are healthy enough to receive a blood stem cell transplant and to determine if they have a suitable donor. That usually takes anywhere from 4 to 5 weeks to complete. After that is completed, the patients are hospitalized and they are given conditioning. This is a term that relates to medications that are given in preparation for the infusion of the donor stem cell graft. That usually takes anywhere from 7 to 10 days. On day 0, the donor stem cells are collected and infused into a specially placed catheter in the patient. And as I mentioned before, those donor stem cells will go to the bone marrow factory and set up shop. Importantly, what happens during this time, however, is that the white blood cells in the body go way, way, way down. And in the weeks after getting chemotherapy, our patients become quite sick. They can have some sores in their mouth. They can have some vomiting and diarrhea. The patients are at risk for infection because their immune system has been completely destroyed, and they may also have some problems with their liver or their kidneys. But this is why it's important to be in a hospital that specializes in blood stem cell transplant, where the team is well suited and well trained to take care of all of these problems. Many times a growth factor or fertilizer for that blood stem cell garden is given, and that helps the blood stem cells come back. And anywhere from 2 to 3 weeks later, the donor blood stem cells are now setting up shop and giving rise to all of the new cells in the blood and the immune system, and the white blood cell count comes back to normal. At this time, our patients feel better, and they are in a position to prepare to get out of the hospital. Unfortunately, there are some complications that occur after the blood stem cells from the donor return, and these are called graft versus host disease, forms of inflammation in the lungs, and some other infections that may be problematic. Again, a main reason why it's important to be in a hospital that knows how to take good care of our pediatric patients who are having a blood stem cell transplant. Somewhere between 6 and 8 weeks later, patients can be released from the hospital. And while you can go home, it still will take some time before you can go back to school, because your doctors and nurses have to be aware of other complications. Sometimes this graft versus host disease problem can occur later. There can be problems with the lung and other organ systems, and there are other late effects that we have to pay close attention to as our patients are recovering from transplant and moving on to happily ever after. Many times when an allogeneic stem cell transplant is given, remember that's the stem cells from a patient other than the from a donor other than the patient, special medicines are put on board to make sure that that donor blood stem cell graft behaves itself when it's in its new environment. It's important to know a couple unique aspects about blood stem cell transplant. Blood stem cell transplant is simply not a procedure. Actually, the procedure itself is rather lackluster. In the end, it looks like a blood transfusion, not some fancy surgery. What's most important for successful outcomes is the coordination of comprehensive specialized care. This is critical in the days, weeks, months, and years after the transplant. For this reason, it is very important to make sure that you are in the good hands of an experienced transplant team who is experienced in transplant-related complications, like graft versus host disease, acute and chronic lung injury, and issues related to reconstitution of the immune system and making sure our patients stay free from infection. As our patients recover from the bone marrow transplant procedure, it's important that their caretakers pay particular note to late effects to make sure that our survivors are actually thriving and getting back to school and back to the workplace. It's also very important to be in the hands of an institution and a team that has access to ongoing cutting-edge research, both in the laboratory and in the clinic. So when should blood stem cell transplant be considered for patients with aplastic anemia or other bone marrow failure syndromes? Well, that really depends on several issues. Firstly, what type of donor is available? Is there a family member who is matched? If that is the case, then a patient with aplastic anemia would likely go to a blood stem cell transplant right from the start. If a match is not apparent, is there a match in the unrelated donor registry? If this is the case, patients may actually go on to receive other forms of therapy before considering a transplant. We also consider the patient's age, response to immunosuppressive therapy, the type of medicines that we might give prior to the transplant, and also special consideration is given to the stem cell source. Should we collect those blood stem cells from the bone marrow, the peripheral blood, or from the cord blood? So in summary, blood stem cell transplant remains a very important curative therapy for a number of patients with marrow failure syndromes, including severe aplastic anemia. Importantly, outcomes continue to improve, particularly when blood stem cell transplants are delivered using a matched related family member donor, but now improved outcomes are also being seen when we are using a matched unrelated donor from one of the national and international registries. Matched related donor blood stem cell transplant remains the treatment of choice for patients with severe aplastic anemia who are less than 40 years of age, and if a match-related donor is not available, then immunosuppressive therapy continues to have excellent outcomes as well. Remember, those medications can include antithymocyte globulin, cyclosporin, and in some cases, Cytoxan. It is important to know that we are making successful strides in using alternative donors for blood stem cell transplant, and this can include mismatched family members or haploidentical donors, and also using cord blood as a stem cell source. Another important point is to remember that patients in the adolescent and young adult age group face very unique challenges during the pre- and post-transplant period that may impact outcome. It's important to be aware of this and important to ask your doctor if the doctors or institutions that he works with actually specialize in AYA patients. It's very important to know your options. Life is all about them, so don't be shy about asking your doctors, your nurses, or your social workers all the questions you can think of when it comes down to your bone marrow failure syndrome. There are some barriers to continued success that we are continuing to work on. In many parts, blood stem cell transplant is built on the premise that more is better. So if we give higher doses of anti-cancer or conditioning therapy, then that should do the trick because we are able to use a donor stem cell rescue. However, those high doses of chemotherapies can cause many problems. They can cause regimen-related toxicity that includes infection, risk of bleeding, and injury to many organs. When you're getting an allogeneic blood stem cell transplant, those stem cells from someone other than self, graft versus host disease remains a main complication. And the target tissues there are the gastrointestinal tract, liver, skin, and lung. The incidence and severity of graft versus host disease increases with unrelated donors. Sometimes, in the case of leukemia or MDS, there can be a relapse of underlying malignancy. However, in the case of other marrow failure syndromes, like aplastic anemia or PNH, that is not an issue. So we don't have to worry about that being a barrier to continued success. As I mentioned before, the good news is research that's being done all across the country and all across the world is improving outcomes for the use of blood stem cell transplant for patients with bone marrow failure syndromes. The future directions as we finish up include the following. We are working to improve outcomes using alternative donor transplants. Those matched unrelated donors or cord blood units or even mismatched unrelated donors, or in some cases we can use brothers or sisters that are only half matched. We are also working on optimizing the use of immunosuppressive therapy. We now know that horse ATG seems to be better than rabbit ATG. We are also developing new agents, including medicines like high-dose Cytoxan and Campath that may actually be effective immunosuppressive therapies as well. It's important to identify measures that may predict outcomes and success. From a blood stem cell transplant perspective, we are doing work to optimize or refine conditioning regimens so that we can reduce toxicity and long-term side effects. Importantly, we are also working at developing advances in the prevention and treatment of graft versus host disease so allogeneic blood stem cell transplant can be a safer procedure. In conclusion, what are some discussion points you should have with your doctor? Always have patient and family members typed as soon as possible. When you go to see your doctor or your nurse, make sure you bring people with you so that there are more than one set of ears listening to what advice is being given. Request a visit with a bone marrow transplant specialist. If it looks like a blood stem cell transplant, may be the way to go. Remember, if no family match is available, ask your doctor or nurse to request an unrelated donor search. That can be done through the Be the Match and cord blood registries. It's important, again, to know your options, even if you don't need to exercise them all. If you are starting immunosuppressive therapy, make sure you understand the approach to first and second line agents, the timing for follow-up, and the impact of iron overload on your health as you continue to require blood or platelet transfusions while waiting for the immunosuppressive therapy to work. If you're an adolescent or young adult patient, ask if specialists are available and have your mother or father consider a pediatric program where there may be specific expertise in AYA patient populations. In closing, I'd like to thank you for your attention today, and I'd like to acknowledge my colleagues at the Johns Hopkins Bloomberg Children's Center in the Blood and Marrow Transplant Program, the members of my laboratory, and certainly all of the patients and their families that my team has been blessed to serve over the last several decades. We've also been blessed with significant funding support from the U.S. government, from the Leukemia Lymphoma Society, other societies, and some local foundations, including the Meredith A. Cowden and a Spark of Hope Foundation. So thank you for your attention today, and I would be delighted to take questions.
Thank you, Dr. Cooke, for an excellent presentation. We do have a couple of questions that came in while you were speaking. Could you reiterate what bone marrow failure is?
Certainly. Bone marrow failure, in simple terms, is a situation where the bone marrow factory is simply not doing the job it needs to do. In the case of aplastic anemia, the factory workers can be considered on strike. They are simply not showing up to work every day. When that happens, the blood cells and immune cells are simply not being made any longer, and that is a state that is not compatible with healthy living. Our patients can become anemic, they can have increased risk of bleeding, and they are prone to infection. In other cases, the bone marrow factory workers may come to work, but they are making defective products. And examples of that are myelodysplastic syndrome and PNH. In those cases, genetic dysfunctions of the stem cells, the blood stem cells, may be causing the underlying marrow failure. It's also important to know that in aplastic anemia, there are two basic types, acquired and inherited. The vast majority of types of aplastic anemia are acquired, and most of those are called idiopathic, meaning your doctor or nurse does not know the cause of the underlying aplastic anemia. What is going on is that the immune system is attacking itself. It's unfortunately attacking the bone marrow factory workers and killing them off. It's important to be able to reset the immune system, and that is what some of the immune suppressant therapy is intended to do. There are also situations where infections and sometimes toxins can cause damage to the bone marrow, leading to a state of aplastic anemia. In aplastic anemia, there are also some inherited forms as well, including Fanconi's anemia, Shwachman-Diamond, and dyskeratosis congenita. These are more rare, but many times are associated with other physical findings that can tip off doctors and nurses that a form of hereditary aplastic anemia is operative rather than acquired. And this is important to know because sometimes the type of therapy needs to be altered.
Thank you. We have another question, Dr. Cooke. If the patient is not a candidate for a bone marrow transplant, what other treatments are there for bone marrow failure syndromes?
That's another excellent question. And as I was mentioning before, most of the therapy is related to suppressing the immune system, at least in the case of aplastic anemia. And so there are medicines called ATG, cyclosporin, and more recently the use of a medication called Cytoxan, which can be used in an attempt to reset the patient's immune system so the immune system learns not to continue to attack the blood stem cell factory workers. Those are the main forms of therapy for patients who are not eligible for a blood stem cell transplant or do not have a suitable match. In the case of myelodysplastic syndrome, blood stem cell transplant does remain one of the best curative options. So if you don't have a good family member matched, this is the case where your physician will likely be checking the unrelated donor registries to see whether or not other suitable donors may be available. In the case of PNH, there is a very specific protein that is lacking on the red blood cells that leads to an increased propensity for red blood cells to hemolyze or break down, and also is associated with the form of marrow failure that is associated with PNH. In this particular case, there's a specialized drug called eculizumab that is being used in clinical trials to see whether or not this could be a good medication for patients with PNH who do not otherwise have suitably matched donors for a blood stem cell transplant.
Excellent, Dr. Cooke. We did have a few more questions that came in. As a doctor, how do you help the patient decide what treatment is best?
Another excellent question. I think it's all about options. It's important to know, as we showed in one of our slides earlier, it's important to know the age of the patient, whether or not the patient has a suitably matched donor, what the underlying diagnosis is, and how healthy the patient is. And based on some of these basic bits of information, we can then provide consult to the patient and our families to determine the best approach. In some cases, the use of immunosuppressive therapy may be the best first start. But again, if our patient has severe aplastic anemia and happens to have a suitably matched family donor, then a blood stem cell transplant would be the way to go, particularly if the patient is healthy and if the donor is readily available. In every case, it's important to take a careful history and physical exam of our patients and to make sure that we address all of the potential options on the table. Once the options are laid out, it's important to help counsel our patients and families to make the very best decisions. And this is usually driven by results in the medical literature that have demonstrated which therapy is superior in a given situation.
Thank you, Dr. Cooke. We just had two more questions. The next question is, can you explain more about a cord blood transplant and who is eligible to receive that?
Absolutely. As I showed in one of my slides, over the last decade or 15 years or so, the use of cord blood stem cells has increased significantly in the pediatric patient. Remember, these stem cells are collected from the placenta via the umbilical cord that is available through healthy newborn infants. These cells are then collected, they are frozen, and before they're frozen, they are typed so that we understand what the basis of some of the genetic code is. Then we can go back and see if our patients are in need of a blood stem cell transplant, whether or not their genetic code matches one of the literal tens of thousands of cells of cord blood stem cell units that are frozen. The advantage of using a cord blood stem cell source is, as I had mentioned, these cells tend to be more primitive. So they are a little bit more forgiving when they find themselves in a new environment, aka the environment of our patients. That has led physicians to use mismatches in cord blood stem cell transplant more often than not, particularly for patients who have leukemia. However, for patients who have aplastic anemia, the use of cord blood is still somewhat experimental and should be used only in the context of a highly skilled and trained blood stem cell transplantation program. I think it offers terrific opportunities in the future, but at the moment we still haven't completely harnessed the power of these blood stem cells, at least for the use of many patients with marrow failure. Blood stem cells from cord blood units are, however, used for patients with myelodysplastic syndrome and with leukemia more frequently than for patients who have aplastic anemia.
And the last question we have, are there other illnesses that can occur as a result of having aplastic anemia, MDS, or PNH?
Another excellent question. And some of these illnesses can be related to whether or not patients who have aplastic anemia have other hereditary problems like Fanconi anemia or dyskeratosis congenita. In those cases, the underlying syndrome is associated with other medical problems, and it's important to discuss those potential issues with your physician and nurses. The other issues that can come up when patients have forms of aplastic anemia or other marrow failure syndromes are the problems, the medical problems that occur during treatment. So remember, in each case, blood stem cells are not being made in a functional manner, and that puts our patients at risk for infection, bleeding, and anemia. Many of the medications that we use to treat bone marrow failure syndromes, those immunosuppressive regimens, can also predispose our patients to infection. So it's very, very important to make sure you contact your physicians and nurses if you are not feeling well, if you have fever, if there's any evidence for significant bleeding or bruising, or if you become short of breath or particularly pale. This would be an indication that something else is going on and that you may need to get medical attention ASAP. The issues related to other medical problems are a very big issue after transplant, and this is why the transplant procedure is not something that just occurs in a day or two, but requires care that is delivered over the days, weeks, months, and years after transplantation. And in that case, a specialized blood stem cell transplant program will be able to provide the comprehensive care that is needed to make sure that any medical issues that come up following the blood stem cell transplant procedure can be addressed in a timely and efficient manner.
Thank you, Dr. Cooke, for an informative presentation and also for your time. And on behalf of the Aplastic Anemia and MDS International Foundation, I would like to thank each of you for taking the time to listen to this program and for making us your resource of choice for information on bone marrow failure diseases. If you would like to view similar programs or the program that Dr. Cooke mentioned with Dr. David Margolis on the Bone Marrow Garden, you may do so by going to our website, www.aamds.org, to view the Bone Marrow Garden presentation. Again, if you have any questions, you're welcome to send us an email via help, H-E-L-P, at aamds.org. Again, that's help, H-E-L-P, at aamds.org, so that our patient educator can respond to your inquiry. Again, thank you for joining us, and please remember, we are here to provide you with answers, support, and hope. Have a great day.